Okay, so we're going to talk about central lines. You can see the multiple reasons. They're kind of listed out for you. Of course, these are also on your recorded lecture slides, but here's just kind of listed for you. Here's the reasons why. Here are the different types that we talked about. So which of the above types can be used for short term, or which ones can be used for long terms? So really, most of these can be used for long terms. The ones that are for short term only, or just our regular non-tunneled central lines. So our non-tunneled central lines, they are short term only. So really just for a few weeks. And the reason why they are the most risk for infections. So non-tunneled central lines, those are going to be the most risks for infections. Why are they the most risk for infections? They really just provide this really short access. They don't have this like tunneling. So we have this insertion to these very large vein. Um, we access this very large vein, which we're going to talk about the insertion site here in a bit. And then it goes into the vein, and then a very short distance later, it is in that superior vena cava. So we're right towards the heart very closely. So we have this very short distance where we're traveling. So insertion site, right there, we have this entry for bacteria and organisms. And short traveling, we just have a higher risk for infection there. Right there at entry, and that so because of that, we really want to keep those in for a shorter time. And so that increased risk, that's why they're also short term. And because of that shorter distance to travel, and that the entry, the insertion site, and that being where we're manipulating the ports and everything also at the same site, being that entry point, increasing our risk, that's also increasing our infection risk. So what's the difference between the tunneled and the non-tunneled? So the non-tunneled, you basically, as you would do with an IV, just a peripheral IV, you poke the site at the point of the vein, you thread your needle in there, and that's where you're going to access the site. So obviously it's not quite as short and simple with a central line as it is with the peripheral, but still it's more short. You're not threading it, you're not tunneling it under the skin. So your access site is your access site. That's where you're pulling it out. That's where you're going to manipulate it. That's where you're going to have your access ports. So you're just not tunneling beneath the skin. So where a tunneled central line is, you have your access, but then you're going to pull those ports and everything gets pulled to another area. So you access it, you then thread it underneath your skin into another area, and then that's where those sites get pulled under. So you're not actually manipulating everything at the actual venous access. So you're not actually having this gaping hole where that vein, that open vein that leads directly to your cardiac site, is at that point. So you do have an access to a venous site, but those are just the port at that point. So you don't have another open area. So it is tunneled beneath the skin. So whereas a non-tunneled, you have that open site, it gets pulled out, it gets stitched in place, and it does get, the dressing, and of course we do our DuraPrep, and we have our cleansing, we have all that stuff for the infection control, but still, because it is just kind of this open, area without that extra protection, we're at a higher risk. So then talking about where's the insertion type for each, or insertion site for each type of central line. Of course, this can be found in the book and discussed elsewhere, but we'll just kind of throw it on here as well. So the non-tunnel central lines and the tunneled central lines, the internal jugular vein, subclavian, and the femoral. And yes, it is pronounced femoral, not femoral. And listen, instructors, and I will say it wrong every once in a while, and so you will hear people say femoral, but it is actually femoral, and I only know that because doctors have made fun of me for saying it wrong, but it's femoral vein, not femoral. So that is where those central lines, tunneled and non-tunneled, can go. The PICC line is going to be in your AC site. The preferred site is basilic vein, and then cephalic vein can also be used. Of course, non-tunneled central lines and tunneled central lines both have to be put in with physicians. Non-tunneled usually put in at the bedside. Tunneled, you're usually more of an operative type procedure, although they can be put in like in interventional radiology or an OR suite, but they do require more intervention. Non-tunnel just can be put in usually with most of your ER doctors are certified. Most of your internal doctors in your hospitals are able to perform those. With your tunnel, you usually have to extra certification for that. Now, your PICC lines, your RNs can get certification, so you will possibly be able to get certified for that. I actually am not certified. I've never put in a PICC line. I have assisted other nurses with putting it in, but it is a procedure that a lot of nurses are able to get certified for, so it is something that you may be able to do, and you can also assist with that. So you can put that in the bedside. And then the implanted ports is an operative procedure. So another thing that if you have a aseptic interventional radiology suite, you may be able to put it in there or into an OR suite as well. So it is an implanted surgical procedure where you will have that implanted underneath the skin. There is sedation involved in that, so it is considered an operation. And it will be implanted under the skin. It is into a major vessel, and then it is threaded into, oh my gosh, that superior vena cava. And then that would be like implanted underneath the skin, and then it has to be accessed for medication. All right, so we're looking at Emily Smith. She's a 42-year-old female, and she has septic pneumonia. She has an order for placement of a non-tunneled central venous catheter because she has poor peripheral venous access. So what would the nurse do first? So this is for you to understand. It is a type of surgical or procedural type or it is a surgical type procedure, even if it is done at the bedside, and it does require consent. So the first thing that you would need to do is make sure that the patient has informed consent, make sure the physician has discussed with her the risk and benefits. And remember, because we are headed around the patient with accessing this with needles, that one of our major risks for this is going to be, oh my gosh, pneumothorax, so respiratory issues are going to be a big thing. So first thing we're going to do, informed consent is the big thing, because if we're not going to be able to get this done, we won't move on for the next thing. And then once again, we talked about the physician is going to be the one that is going to insert the catheter. So what we're going to be doing is preparing the supplies, making sure that the patient understands, you know, that they've gotten the informed consent. So we're just reinforcing the education, making sure that they don't have any questions, that they understand the risk and benefits, and that they're fully informed as well. All right, so Miss Smith, she's signed her consent forms, and we're preparing the patient for the bedside insertion. So how should the patient be positioned? So we want the patient's head down for this procedure. So head down or supine. What should the nurse or the doctor wear? So we're going to be dressed like we are in a surgical suite. So we're going to be fully scrubbed in. We're going to do a septic scrub. We're going to be wearing surgical wear. So we're going to have the surgical gowns on. We're going to have hats on. We're going to be wearing masks, and we're going to be wearing sterile gloves for this. What should the nurse do to prepare the site? So we are going to prep the site with DuraPrep. So before, of course, we do this, we want to make sure the patient doesn't have any allergies, and then we're going to prepare the site with it's usually a chlorhexidine DuraPrep type medication, and you need to make sure that we clean that site off with the DuraPrep, but we also want to make sure that that site is dried fully, because remember, when we're prepping things, part of the action is drying completely. So if it dries completely, that means that it's taken the time to actually kill all the microorganisms. So make sure that we've given it time to completely dry. And then when it asks about the sterile drapes, head to toe, just like if we were in OR, the only spot that is open is the spot that we are surgically working on. So the patient will be draped head to toe. So they're not going to be able to breathe on that site. They're going to be completely covered. We're only going to see the prepped area that the physician has worked on. So the patient will be faced head down or supine. We're prepping the site. We're draping the site. We are surgically prepared. So we're going to be fully aseptic. We're going to do our scrubs. We're wearing surgical wear, surgical gowns, surgical gloves. Patient is scrubbed in. They're covered. And that site was dry. All right. The doctor completes the central line insertion. The patient's right subclavian vein, and they sutured the central line into place. So what type of dressing should be applied? So this is a transparent, semi-permeable polyurethane dressing. So basically, that semi-permeable is just so that moisture doesn't get stuck in there, because you don't want to have the ability for like fungus and rashes and things to form underneath there. And how long can the dressing stay in place? So what I want you to remember is that the dressing stays in place for 7 days before you have to change it. Now, in actuality, once you actually just put it in, typically you'll do a dressing change in 24 hours based on your protocol. This changes. Sometimes you don't have to change it for 7 days after you place it. It's going to be different for every facility, whatever their protocol is. So sometimes they require a 24-hour change. Sometimes they wait for a week. But most facilities, after that first change, you have 7 days, and that's what you need to remember. So dressing changes every 7 days and as needed. So remember, as needed. If you have a soiled dressing, you need to change it. If you have a dressing that's coming off, you need to change it. If you have a dressing with a bunch of drainage, you need to change it. If you have a dressing that has it's just not intact, you would need to change it. So as needed is very important to remember as well. But 7 days, it is a transparent, semi-permeable dressing. So transparent so we can see it, semi-permeable so it's not holding a bunch of moisture in place. All right, so Miss Smith, she's 3 days post-insertion at this point, and she has that triple lumen central line. It's negative pressure. So if it's negative pressure, it's going to mean that the pressure is, I got lost. It's going to allow blood to move into the port, because that negative pressure kind of pushes it back into that port. And that should say needleless ports, not needless ports on there. So if it's positive, it's going to push out of the port. So it kind of pushes into the vessels. If it's negative, it pushes into the port, so the blood's coming into it. If it's neutral, it just kind of like sits there. It doesn't really push one way or the other. So then it's been confirmed for placement by the chest x-ray. She's receiving antibiotics daily through the line, and nurse is preparing to administer IV Lasix. So what should she scrub the site with, and for how long? So there's really 3 different things that you can scrub the site with, and that's really 70% or higher alcohol, chlorhexidine and alcohol solution, or there's like a povidone iodine solution. We really don't use the povidone iodine solution, because if you were to do that, and really the only time I ever see that is like if a physician is doing some kind of like special procedure. It takes forever to dry. It's just really not something that you see in practice. So really just kind of scratch that. You don't necessarily need to know that, other than it happens. So it's just really not an intervention you see. So there's really 2 things that you'll see, and that's the chlorhexidine alcohol solution or the 70% and higher alcohol solution. So 15 to 30 seconds is really how long. It's going to be different depending on the recommendations from your manufacturers, but that is what we need to know. So 70% alcohol, chlorhexidine and alcohol solution, and really 30 seconds is what I like for you to know, unless we have something that tells us we can use it less. So 30 seconds is really good for me. So what size syringe should she use when establishing patency? So anytime you're establishing patency on a central line, you need to use a 10 cc syringe, because if you use a smaller one and you're establishing patency, you could potentially have a high pressure with those smaller syringes. So 10 cc is for flushing and establishing patency. After that, you use the smallest syringe that you need to use. So it's just like every other IV after that point. But when you are flushing, you need to use your 10 cc syringes. So it kind of works out about like how you're doing it with a peripheral IV anyways, because we're using our pre-packaged saline syringes typically anyways. You need to use a new saline syringe for every single flush, every single time anyways. So it typically works out how it's supposed to anyways, but because they're central lines, because of the way that the ports are, you just need to be very careful that you, when you're establishing that patency, before you know whether the lines are working properly, that you make sure that you only use a 10 cc syringe. After that, it's just the size syringe that you would use for your medication. And that's actually the answer for 3, so I've answered that already. With what should she flush before and after administering medication. So that is the normal saline. So it's just like when you give medication, you're going to establish your patency with your normal saline. You're clearing your line. You're making sure that you don't have anything incompatible. You give your medication. You're going to clear your line. If you give another medicine, you're clearing your line with your normal saline afterwards. Of course, if you have a medicine that you know is completely compatible, you may not have to do that. It just kind of depends with the compatibility, but you can flush in between as well. Some central lines, depending on the manufacturers, require heparin. Most these days do not. Almost all of them did before, but we're seeing a lot of them do not require heparin anymore. If you have a positive needleless port, a lot of them do not require heparin any longer. And when should she clamp the tubing? And because this is a negative pressure port for her, she should clamp the tubing prior to removing that saline syringe. So while she's actually flushing, prior to actually ending that flush, at the end of that flush, before she removes that, she should clamp it before that, because she wants to keep that pressure positive before she clamps it. If it was a positive, she would remove the flush and then clamp. If it was a negative, or if it was a neutral, she could just clamp at any point. It would not matter. All right, case study 5. On day 5, she receives an order to draw labs from Ms. Smith's IV site. The facility uses the dead space method, and what are the steps for that? So the dead space method and the discard method are really the 2 methods that I have seen in use. I want you to know the dead space method because that is the most commonly recommended method by evidence-based. It seems to be the least kind of infection risk, and we lose the least amount of blood. So it's relatively simple. You would go in, you would stop the medication for per policy. Typically, it's going to be anywhere from 15 minutes to 30 minutes, depending on the medication and the facility policy. And then you would flush the IV site. You would withdraw from the port until blood entered the syringe. You would then discard that blood, and then you would then draw the amount that you would need from the specimen, and then you would just use that for your specimen, and then you would flush the site again, and then you would be able to resume using the central line just like you were before. So that way you really only lost a very small amount of blood, and you would not, you really only, there's very small amount of waste. You didn't have to like poke and prod, and you weren't manipulating the IV site very much. So there was a just very small amount of infection risk for that. Okay, so later on day 5, the nurse cannot aspirate blood or flush the brown port in Miss Smith's central line. So what steps should she take? So first and foremost, and I have seen this so many times, I know it sounds really simple, make sure the port is unclamped, because it sounds so silly. I've done it. I've seen students do it. I've seen other nurses do it, but sometimes we miss that something is clamped and we think it's unclamped. So just make sure that it's clamped. So ask, is the tubing connected? We want to make sure that it's not compressed or kinked. Sometimes it is kinked in a weird spot that we don't realize. Make sure there's no devices that are clamped. And then we want to look at other reasons as well. So sometimes it's positional. So we can have, it could be something about the patient's position. And sometimes it can be something inside intraluminal, and sometimes it can be extraluminal. So there are things intraluminal that can be occurring, and sometimes there can be something extraluminal. So first of all, if it is positional with the patient, so extraluminal, we could have something like pinch-off syndrome occurring. So before we start trying to like break up blood clots, we could have the patient take their arm and just reposition it. So you may try turning the patient, lifting their arm up, moving them around, and see if any of those steps actually can, of and in themselves, could help you to, you know, if we're able to aspirate blood or flush the catheter. And if that happens, that's still something we need to report for the physician, because that can be sign of an extraluminal occlusion, showing us that we have a pinch-off syndrome, because that can be signs that, you know, we're having compression between that clavicle and the first rib. And if that continues, that can actually break the catheter. And we don't really want the catheter to break off between the client. So it's something that really needs to be addressed. The physician needs to be aware of it. The other things that can happen is we could have a thrombus within one of the lumens. So you may have to work with like interventional radiology, where they may have to go in and see if they can break up the thrombus, or they may have a fibrin sheath that may occur at the end of the tip of the lumen, and so that can keep us from being able to aspirate blood. Typically when we see that, what you can get is you can usually flush, but you won't be able to aspirate. So what you'll see is, like, if we can't aspirate, you may still be able to get a flush, but it's just not as good. And so, you know, if we're not able to flush or aspirate, we would probably be more suspected that it's intraluminal versus extraluminal. But you may be able to still use the port, but you would be using it cautiously, or you may only use it for flushing. You may not want to use that as one of the primary sources. But it would still be something that you would want to go ahead and report to the physician, and then they would let you know if they want to go ahead and look into it further, and they'll let you know if they want to intervene or use those ports further. All right, so we've moved on day 7, and she's actually gotten on quite a bit better, and the physicians decided, you know, we're going to go ahead and go home, and we're going to go ahead and remove the central line. So we need to know what supplies that were going to be needed. So it is sutured to her, so we do know that we're going to need a suture removal kit. We're going to need some 4x4s and some tape. So that's really about all that we're going to need. It is not a sterile procedure. We are going to use clean gloves. The 4x4s are going to be sterile, but It's not a sterile procedure. Once again, the patient's going to be positioned in a head down procedure. And that's really just going to help us keep from getting the air or the blood's going to flow down. We're not going to have that air position whenever she's removing the catheter, or we're removing the catheter, but when she's getting that catheter removed, it's going to help us keep from air flowing into that large vein. And now we'll kind of talk about the steps really quickly. So, patient is going to be head down. We will go in, we'll remove the dressing. We'll be wearing clean gloves. You'll remove the dressing. You'll clean around the site. You'll usually with a DuraPrep, but it may be something different depending on your facility's policy. You'll use a sterile suture removal kit. You'll remove the sutures. And then you will take the sterile 4x4s and you will put it loosely over the insertion site. So you'll just hold it loosely over the insertion site, and you will ask the patient to either do a Valsalva maneuver, so that's bearing down as if they're taking, like as if they're having a bowel movement, you know, they're pushing down, bearing down, or if they're not able to perform that, a lot of our older patients aren't able to perform that, you have them take a deep breath in and then to breathe out slowly. And as they're breathing out slowly, so only as they're exhaling, you're going to remove that. It's not going to be like super, super fast, but you're going to remove it kind of steadily, like as in one steady motion. And then when you remove that, you're going to hold firm pressure for a minimum of 2 minutes over the site. So it's either while they're bearing down or as they're exhaling. So while they bear down or exhale, what that does is it creates this positive pressure so that there's no way that they're going to breathe in and create an air embolism into that large vein. And then you're going to hold positive pressure. Minimum of 2 minutes over that site. Longer if they have a risk of bleeding, like they're on anticoagulants or they have missing clotting factor or anything else that could cause their blood to clot slower. So 2 minutes minimum, firm pressure, Valsalva maneuver, head down, all these things that I just said, super important. Okay. All right. Thank you.